So
But
we're going to talk.
we can see your slides fine.
Okay, great. Thank you. If there's anything that I either lose sound or you can't see something, just let me know and we'll figure it out. I'm going to talk about the involvement of palliative care in heart failure. No disclosures. Um, we're really going to just review what heart failure is, the types of it, and the classification, the role of palliative care in advanced heart failure. We're going to talk a bit about some of the barriers to palliative care involvement, and even discuss some of the solutions. I do see patients or in the heart failure clinic, and I can share some of my experiences around that as well, and would love to hear anybody else who has that. And then also discuss some special considerations like removal of advanced therapies and even the lifestyle medicine interventions. Starting off with what is heart failure? I'm going to move this piece here. Okay, there we go. Heart failure is actually not a disease. It's actually a very complex clinical syndrome. And you all know this, but it's really when the heart is unable to pump sufficient blood to meet the metabolic needs of the body. And that can be due to a variety of reasons. It can be caused by some congenital anomalies, some structural abnormalities, dilation of the heart, stiffness of the heart. So there's various causes of that. There are some symptoms that are pretty universal with heart failure. Dyspnea, fatigue, PND, orthopnea, edema. These are all the things that we see in heart failure. Some of the clinical signs that we see are pulmonary congestion, JVD, peripheral edema, hepatomegaly, ascites, and just weight gain due to fluid retention. Now, the diagnosis of heart failure is not just by a blood test or even just an echo. It does need to have the evidence of cardiac function abnormality. So even sometimes we might see a slightly reduced EF without the signs and symptoms. We don't really call that heart failure. So you can see that heart failure is really just a complex clinical syndrome. The reason why we're talking about heart failure is because it is really, the prevalence is increasing, but it just here in, gosh, 4 years, a one in every 33 adults in the US will have heart failure. That's really quite a bit. Currently, we have 6.2 million adults with failure. And in 2018, it was about 13.5% of the terminal cause of death on death certificates. The costs are really just very high, and currently we're estimating that it's going to be about $30.7 billion, which is likely to double again by 2030. It is the most common cause for the 30-day readmission rate, which we know that CMS does penalize hospitals for that. And it consumes about 1 to 3% of total healthcare dollars. So it is a very costly chronic disease for our healthcare system. And like other chronic diseases, the health disparities are prevalent. It's chronic diseases require are impacted by social determinants of health to a great deal, and heart failure is also impacted by that. So in heart failure, the racial and ethnic disparities. Black patients develop heart failures at younger ages. They have a higher hospitalization rate and even higher mortality. They are less likely to receive guideline directed medical therapy or even advanced therapies. Now, a point here is that race is a social construct. And in the past, there has actually been recommendations around race-based prescribing, which recently that has been eliminated. But what is important to recognize is the impact of social determinants of health. So, understanding, for example, zip codes or those kinds of things that impact patients' ability to access healthcare. But nonetheless, Black patients do suffer the disparities. The socioeconomic and social determinants of health, again, lower income, when there's government insurance, housing instability, those kinds of things are just associated with higher heart failure hospitalizations and worse outcomes, and it makes a lot of sense. Um, these sex and gender disparities, women with heart failure actually have a higher symptom burden and worse quality of life, but they are also less likely to receive advanced therapies. And if we think about, we talked about Black patients have a higher hospitalizations and higher mortality. So this transsectionality really gets worse when we think about, for example, Black women. Um, It is also geographical and health system disparities. There are the rural areas just have, again, less access and therefore just worse outcomes. Even in disparities in advanced and palliative care, marginalized populations are less likely to have palliative care involved in their care, and therefore they do end up having a higher symptom burden. And the Heart Failure Association of America identifies access to primary and specialty palliative care as a clinical priority, particularly for marginalized communities. But in spite of that, we are not seeing the improvement that we'd like to see. Um, the strategies to reduce the disparities really is complicated. It's a we'll talk about this in a slide here in a bit, but really it has to be multifactorial. Really addressing all levels, individuals, systems, and societal. Um, One of the things to also I find just really important is that racial and ethnic minorities do have the highest incident prevalence and hospitalization rate, as I mentioned before. But in spite of our awareness over the last 2 decades, the disparities have actually worsened and not improved, particularly in our African American patients. The thing about these disparities that they are predictable. We know what they are. We know how they impact heart failure, and therefore they are preventable. We just again the interventions to address these disparities is complicated, but really it's something to pay attention to. This is a slide that sort of shows all of the places, all of the points of where interventions to address the disparities need to happen. And when you look at this, you can see it makes sense that it's so hard because it's not just about it's not just about, for example, educating the patient or having trigger truths for palliative care. It really requires a multifactorial, comprehensive plan for intervention at multiple points. This is true for all chronic diseases, but particularly so for heart failure. Heart failure and health literacy. Heart failure is one of the most health literacy dependent chronic diseases, and it makes sense because it is so complex, and therefore for patients to understand what it is, it really does take a lot of education and helping patients really understand what heart failure is and the impact that it has. There is an association between health literacy and health related outcomes for chronic diseases, and again, particularly so for heart failure. Inadequate health literacy was associated with a 20% increase risk of being hospitalized, a 15% increase risk of ED visit, and overall poor quality of life and increased mortality. More often than not, The medication adherence gap, so what in the past we've referred to as non-compliant, is really not from lack of motivation from our heart failure patients, but it's really more often due to low health literacy. They just don't understand, and therefore they're not able to adhere to the care plan. And again, this is a modifiable risk factor. It's very impactful on outcomes, and it is something that we can absolutely impact. Um, Moving on to the classification, we used to do the diastolic systolic heart failure, and I'm sure you all see that we really no longer use that. It's been the last few years that we've kind of got away from that. But the types of heart failure, again, according to the EF, the is there's two. There's one with reduced EF, which is um, which is defined as a left ventricular ejection fraction of less than 40%. So if it's less than 40%, then it is heart failure with reduced EF. If it was that, and through the guidelines directed medical therapies, it is improved. We still say that they have heart failure, so we call that heart failure with improved EF. Um, if the EF is between 41 and 49%, it's heart failure with mildly reduced EF. And if the left ventricular EF is greater than 50%, then that is called heart failure with preserved EF. For further, I'm going to just talk about the reduced EF and the preserved EF. The other two, I'm not going to really talk about that. That can be helpful in a clinical scenario for documentation, but for this presentation, we're just going to talk about that and really recognizing that the heart failure with reduced EF is an ischemic, it tends to be an ischemic etiology, where heart failure with preserved EF really is a metabolic etiology. So with a preserved EF, you'll see this in patients that have had longstanding hypertension, diabetes, that sort of thing. The stages of heart failure, they go from A, B, C, and D. And you can see at this slide where I'm really going to focus on are the stage C and D, because this is where our palliative care gets involved. And stage C, this is where the heart failure patients become symptomatic, and they are showing the signs of dyspnea and fatigue and decreased exercise tolerance. Um, Stage D is advanced heart failure. And this is when, in spite of the GDMT, the patient's symptoms become persistent and they are not really responding to treatments. And they're having recurrent hospitalizations and those sorts of things. So, really, the stage C and D are the ones that we tend to see. If you look at the trajectory of the class C heart failure, oftentimes that is when heart failure gets diagnosed, because patients present with symptoms and they're already in stage C. Now, through therapies, they can go back to maybe stage B, or their symptoms might be improved. But it does, after a certain amount of time, the symptoms become persistent, and then they tend to just get they just tend to worsen. The 5-year survival rate of a patient with class C heart failure is almost 75%. So, this is a time where patients can really be impacted by interventions, the GDMT, as well as palliative care involvement. Advanced heart failure, that is the stage D. And if we talk about the New York Heart Association, it's usually a class 3 to 4. Oftentimes we will see LVEF less than 30%. There will be a persistently high BMP. We're going to see the signs and symptoms of pulmonary or systemic congestion. Sometimes these episodes might require inotropes or other vasoactive drugs, or maybe there might be an arrhythmia. And a severe exercise decrease in exercise capacity. So, I mean, you know an advanced heart failure patient when you see them, even without the BMP, you can identify that clinically. Once the heart failure, you can look at the slide. You can see that oftentimes, the heart failure trajectory is progressive, but it's kind of up and down. And what happens is that with interventions, the symptoms sometimes they get better and then they get worse. And so ultimately, though, it does result in pump failure. That will happen. It's a matter of when, not if. Sometimes that when can be years. And sometimes it can be months. It really just depends on the clinical scenario. So, because of that trajectory, that up and down trajectory, how do we assess prognosis? This is always a challenge in palliative care. And some of the risk tools that we can use, the Seattle Heart Failure Model or MAGIC, there's other ones too. All of them have their limitations. The Seattle Heart Failure Model and MAGIC, which is most often used, they work best. The Seattle Heart Failure Model works best for the heart failure with a reduced EF, not with a preserved EF. Magic does have can work for both, but the data is limited about how accurate that is. And you can see these other ones. There's the Barcelona heart failure, which is very accurate, but it needs biomedical markers, which sometimes are not available and they can be expensive. But really, what it comes down to is that using a tool is just that. You can use the Seattle Heart Failure Model or the MAGIC model, but it must be supplemented with the disease trajectory and a clinical scenario. So, looking at your patient's frailty. So, just using a tool for prognosis will not work. And to be honest, I don't even use the tools that often unless I am using as an educational piece for my patients. The clinical caveat is that the tools they predict the mortality, but they don't predict they don't take into account the lived experience. They don't take account for frailty, any cognitive decline, caregiver burden, or any type of a symptom burden, which is a huge part of heart failure. So again, the most accurate prognostication really does come from utilizing the risk scores, but looking at the trajectory and then the clinical judgment. So the palliative care guidelines, there's a wonderful article that I've referenced and it talks very clearly about the guidelines for palliative care and heart failure. And really, what the definition of palliative care and heart failure and the scope is that it should be involved for the entire disease trajectory alongside GDMT. So at the time of diagnosis, like many cancers, palliative care should be involved more often than not. Palliative care gets involved, not even just hospice, palliative care gets involved in end of life care. And all of the major societies, the American Heart Association, the Cardiology Association, support this multidisciplinary approach to address all of this physical, psychological, social, and spiritual distress for patients and the caregivers, recognizing that due to its complexity, the burden of heart failure on patients and caregivers is quite large. So this is a class 1 recommendation for the routine involvement of palliative care really at any stage. So from the very beginning, from the diagnosis, for symptom management to improve quality of life, and then obviously the communications around goals of care. The emphasis on the involvement is a need base, not a prognosis base. So you don't want to look at what you think, oh, maybe this patient's got a year to live and therefore we're going to get palliative care involved. Not at all. A patient may have high symptom burden or even just high caregiver distress. And that really should be the trigger for involvement of palliative care. And like I said, this is a class one recommendation. So both the European Society of Cardiology, AHA, and ACC, are the societies for cardiology. They emphasize that palliative care should be involved for the entire heart failure journey. Um, Again, it should be need-based, not prognosis-based. The European Society guidelines, they do have guidelines that places a higher emphasis on advanced heart failure, which some cardiology centers do use their guidelines. But again, this really should be a need-based and not necessarily just advanced heart failure. The primary components, with primary palliation, is every heart failure physician is a palliative care physician, and every physician is a palliative care physician. So heart failure is no different. But some of the basic things that primary palliative care that cardiologists should be trained in, should be doing at every visit is the symptom assessment and management, which makes sense. Communication and prognostic awareness. Uh, This is probably where I see the biggest gap, um, because oftentimes the health literacy of patients is not accurately assessed, and therefore it's not the efforts to improve it don't happen. The communication around further treatments is not just from palliative care. They do need to come from the cardiologist. Again, this is where I see the biggest gap. And advanced care planning. This is again, this is part of primary palliative care that cardiologists and cardiology clinics should be addressing. Advanced care planning really should be done very early on at the time of diagnosis, just like in oncology. When a patient is seen by a cardiologist, ideally, they should have that advanced care planning as one of the initial intake pieces. And then again, revisited anytime that there's any change, if there's aggressive therapies that are going to be needed, ICD shocks, those kinds of things. So that's the primary palliative care. The specialty palliative care, this, again, palliative care should be involved on a need base. So when there's a symptom management, when the goals of care discussions become complex, or maybe they're not clear, or when there are advanced therapies that are being discussed. Anytime that there's psychosocial distress or caregiver distress, those are all the reasons to get the palliative care team involved. The HFSA has a wonderful article from 2024, which is really an operational guidance on how to integrate palliative care into heart failure. The purpose of this is, how do we do this? Because of the trajectory of heart failure, and it's a lot of times people were just unclear about when to get palliative care involved. They really explicitly describe when palliative care should become a standard component of heart failure treatment. And this is in order to have high quality heart failure treatment, we really do need to have palliative care be a part of that. Um, Again, it needs to be need based, not prognosis based. So the tier model of delivery, according to that article, is that, the primary palliative care, as we just talked about, this is emphasizing that cardiologists are their responsibility to deliver primary palliative care is a part is just as important as perhaps these advanced interventions. Specialty palliative care should be involved, and understanding those criteria for involvement is important because without that awareness, perhaps those triggers, those signs where there are symptom progression or caregiver distress and those kinds of things may not be recognized. And so really looking at those things and developing explicit referral criteria so that those triggers don't get missed. Um, so the three tiers, we talked about the primary palliative care, we talked about the specialty palliative care. The third tier is the advanced or the end of life focused palliative care. This is obviously is hospice care. So you can look at the triggers for all three. For our specialty, tier two and tier three are really where we do come in. Once palliative care is involved, so looking at that tier two, looking at the triggers to involve palliative care, then palliative care can follow along all the way to end of life. For us at Corewell, we do have a hospice and palliative care, and we even though we do there are separate teams, we do work closely. Those teams do work closely together. So once palliative care is involved at that tier two level, we are able to follow them all the way to end of life. The key inflection points, though, is that the involvement of palliative care should be a systemically considered intervention, not just based on individuals, not relying on individuals to recognize the need and therefore get palliative care involved. The other piece to be mindful of, too, is that we do have to look at the resources. Every institution has different resources. Every program is a bit different. So just being flexible about what each institution has available, what their needs are. And so making sure that those delivery models reflect the resources and the needs. So again, it should be systemic, but also have some flexibility on how that might look to tailor it to each community's needs and each institution's resources and needs. Um, Furthermore, the measurement around quality, and now we are required. CMS does have a lot of quality measures around that, but still looking at measures like assessing symptoms. Is there symptom improvement when palliative care is involved? Is palliative care getting consulted in a timely manner? What about the goals of care? Are they documented? Are we pulling in resources for caregiver support? And so there are ways to measure that and follow along that for improvement for quality metrics. This is a great way to show healthcare systems the importance of palliative care in heart failure. And also that tailoring palliative care for specific populations. At Corewell, we do have an advanced heart failure clinic where the patients are at stage D and New York Heart Association class, mostly 3 to 4. And that's where palliative care gets involved. Palliative care does not see the stages A and B. So again, each institution kind of does have their own way of incorporating palliative care. But looking at those special populations, palliative care at Corewell, we also see the heart and lung transplant patients. So, those are the special heart failure populations. But if we were to kind of boil down some easy referral triggers that, if we were, it's easy to think of things, just maybe with a fewer triggers. Anytime there's a patient with a New York Heart Association class 3 or 4 with refractory symptoms, stage D, with recurrent hospitalizations, so more than one or two in the last 6 months. Intolerance to GDMT. So, in spite of therapies, the patients still are having symptoms or they're having high symptom burdens. And then complex goals of care, and or any time there is consideration of withdrawals of advanced therapies or starting advanced therapies. What it's important to highlight, and I know we all know this, that palliative care is not giving up. um, that is still the perception, I think, even from cardiologists. And again, I cannot emphasize this enough that prognosis alone should not drive referral. If you look at those referral triggers, none of them really talk about, life expectancy. We don't talk about the surprise question. We really don't talk about what, the prognosis. It's really about the need for the patients. So, in summary, embedded palliative care in heart failure is really standard of care, class one recommendation, and that referral should occur at the whole throughout the whole disease process, not when there's a treatment failure. And some of the triggers, like as we talked about, are right here. Again, one of the things too is to normalize this prognostic uncertainty. It is okay, and we should say to our patients that we don't really know. We're looking at maybe years or months. The uncertainty is something that we should openly talk about, because as you all know, what happens is when we say 6 months or a year and then patients survive beyond that, then of course we lose credibility. Also looking at supporting the caregivers because of the burden of heart failure. Caregiver burnout is very common, and then also bereavement. Primary palliative care to all heart failure patients. Cardiologists should be trained in that, is particularly the communication and the goals of care. And again, not prognosis based, but need based. Um, this is how do we do it in palliative care? The shared decision making. We use the head, heart, hands, the three questions approach, really focusing on health literacy, knowing the patient, and creating a plan with the patient, collaborating with them, so that each step in their heart failure journey reflects their values and their preferences. Again, symptom management, we're going to talk about that a little bit, and then caregiver support. um, this is a palliative care. This is a randomized controlled clinical trial. This is probably one of the most cited studies in heart failure clinics. And what I'm and the reason why is because if you look at this graph, what they did is that they used two scales: the Kansas City Cardiomyopathy Questionnaire and the Functional Assessment of Chronic Illness Therapy, both which show quality of life and symptom burden. So both showed the orange line is the care alone, and the blue line is with palliative care. The higher the scores, the better quality of life and the fewer symptoms. You can see in using both of those metrics, there was a significant improvement in the involvement of palliative care versus just the usual care alone. This always, I mean, it's interesting to me because this is a great study. There's no question about the outcomes of the study. It is well known, and yet we still struggle with, at least at Corewell, and I know that other institutions still struggle with embedding palliative care in heart failure. Um, so how do we do this? I guess my experience is just make the referral process easy. Don't count on individuals. If there's a way to embed it in your EMR, in Epic, make it easy. Collaborate, and then collaborate some more. There is a culture shift that does need to happen. And that is just takes time, and it takes a lot of communication and education, and a lot of partnership. Um, the automatic triggers for palliative care referral is really a great tool to have. The challenges with that is, sometimes people don't agree on what those triggers are or where they should be placed. So there are some logistical things, but developing the criteria and having automatic triggers really, is is again very helpful because it just takes that subjectivity out. And really, we do not need to change the name of palliative care, to supportive care, or I know there's other names, but that is just really not needed. I think we should be unapologetic about the involvement of palliative care in any subspecialty, and just have that palliative care interventions a part of just high quality medical care. Um, the common symptoms, I mean, and all of you from med school, I mean, we've all seen heart failure patients. There are so many symptoms, and patients have really have a high symptom burden, even if it's periodically. When they are in acute heart failure, the symptom burden is quite high, and it really affects the whole being, right? So just the physical, the psychological, the functional, the spiritual, emotional, all the things, because patients are, because of the markedly reduced exercise intolerance, even things like brushing your teeth or getting ready for the day can become really problematic. The symptoms can occur at any stage. And with GDMT, oftentimes they can improve, but they can still be quite severe when when they happen. And this is not limited to just end stage disease. Things there can be triggers. There could be an infection that can trigger heart failure, or even sometimes changes in lifestyle, those kinds of things. So it's really important that we assess and relieve the distress routinely. Um, and palliative care really, again, when they're involved early on, they can really help with that symptom assessment, and the treatment of some reversible conditions, and provide that support for symptoms alongside the guideline directed medical therapy. So some of the symptoms, the dyspnea and fatigue, are very common. Yeah, and a lot of the way to address both of them is really through the heart failure medications. So the guideline that directed medical therapy, sometimes those needs to be adjusted, and that will help with the dyspnea and fatigue. As a palliative care provider, I really do collaborate with my cardiology partners when optimizing this. Sometimes I do make adjustments, but in communication and collaboration with them. So that's a really important to partner when we're using the heart failure therapy medications. Some of the non-pharmacological strategies, especially as patients become more homebound, just having them sit upright, sometimes just getting some fresh air, a fan, um, and then treating any underlying conditions that but might be making it worse, like, so for example, some anemia, iron deficiency. If there's a sleep disorder, that can make fatigue, or even dyspnea worse, and of course, depression. Um, if the symptoms persist after doing all that, then low dose opioids are very effective, and those can be escalated. And even sometimes in my heart failure patients, as they go they're along their disease trajectory, using long-acting opioids, it can be effective in addressing particularly the dyspnea. The pain and anxiety, also high symptom burden, and oftentimes, the dyspnea and the fatigue and pain and anxiety, they all kind of are jumbled up into one, package, sort of. Pain is often under recognized because sometimes it can be just an ache, just due to the lack of blood flow. A person may just feel tired and achy. It could be severe ischemic, it could be musculoskeletal, and the deconditioning and the edema that can occur oftentimes makes that pain worse and even the anxiety. So, again, looking at the GDMT to address those, whatever can be addressed should be addressed that way. If it's not possible, then using medications. Avoid NSAIDs when I think I always avoid NSAIDs. I was going to say mostly, but that's actually not true. I do not use NSAIDs for treating pain and heart failure patients. Opioids are very effective, and they can be quite safe, even though they do reduce the respiratory drive. Again, when used appropriately, they are very effective to address the symptoms. Um, Anxiety and depression gets amplified when patients are dyspneic. So again, looking at the symptoms are not, they're not in silos. They all come together, and so making that clinical assessment on how to address the symptoms. Oftentimes the opioids can address the pain and the dyspnea. And so that can really help with symptom management. And sometimes it can help patients sleep too. Other symptoms like edema and ascites. Edema is not just uncomfortable and reduces mobility, but it can be psychologically distressing to patients. Even seeing their feet um, just so edematous and having a hard time putting socks on or maybe going out. Those kinds of things can really impact the patient. So it can really affect their self-image. So again, optimizing diuretics, um, using compression stockings, elevating sodium and fluid balance, and good skin care. The sleep disturbances is actually very common. Some of this is due to the orthopnea, anxiety, or maybe there is a sleep disorder. So in heart failure patients, particularly early on, if there's a suspicion of that, getting a sleep study and addressing any sleep disorders is really helpful. Um, so addressing whatever cause there might be, if there's anxiety, maybe even using an anti-anxiety medication, looking at that. And then also going beyond the patient to the caregivers. Um, it's just really hard for the caregivers due to the high symptom burden, oftentimes hospitalizations. So using our interdisciplinary team, which we do so well, in providing that support to the patient and the caregivers, and really help them understand as best as we can what this disease trajectory is like, and support them through that. So again, make the symptom relief a core goal, escalate support when the symptoms get worse, and integrate palliative care alongside therapy. Lifestyle medicine, cardiovascular diseases, actually, lifestyle medicine originated out of cardiovascular diseases because cardiovascular diseases are lifestyle diseases. Um, so the lifestyle interventions, they are more helpful when the patients are in the stage C. Stage D, they can still be helpful, but they are much more helpful in the earlier stages. The whole food plant-based diets, there is a moderate benefit even in stage A. So really, as a preventative measure or very early on, some benefits in stage B to D. Sodium restriction, again, strong for stage A, again, earlier on. A little bit more, it is still moderate for stages B and D. Um, Exercise is just a very, very impactful intervention, and it's actually underutilized. So we don't use the exercise as often as we should. Recommendations regarding that, but even things like yoga, meditation, tai chi, there's actually some emerging evidence about its benefit in heart failure. And some of it could be helping the anxiety, which helps the dyspnea and the symptoms, but definitely it does impact symptom burden and quality of life. Some of the supplements, there's really not a ton. The coenzyme Q10 has a little bit more compelling evidence than the others, but it's really not great. There is one though, the sauna and the thermal vasodilatation, particularly in the earlier stages of heart failure. This has actually been shown to be very, very effective. So those of you who like a sauna, I mean, not just for heart failure, it's actually very impactful for improving metabolic health, reducing risk of Alzheimer's, dementia, and cardiovascular risks. Uh, but specifically for heart failure patients, this study did show the positive impact due to peripheral vasodilatation, and also a little bit there's heat proteins that get released. With the infrared thermal blankets and saunas, which are also protective. So, this is something that can be very beneficial. I do want to talk about some important clinical scenarios. One of this is a patient, he was a 59-year-old with ischemic cardiomyopathy with a left ventricular EF of 12%. He was hospitalized for cardiogenic shock and was started on milrinone and really desired a heart transplant, but was not a candidate for a heart transplant. Um, because he just was just too ill. He initially did well with an LVAD, but then suffered a CVA and became bedbound, was just not able to take care of himself anymore, and no longer wanted to continue therapy. So he reached out to the heart failure clinic and said that he didn't want to continue with the LVAD. So LVAD deactivation is something that does happen. It should be in alignment with patient's goals of care. That's why palliative care involvement earlier on is so, so, so important so that these things can be talked about and discussed earlier on. A couple weeks ago, Gretchen did that fantastic ventilator removal lecture. And if you remember that, I'd love to do this lecture after that because a lot of the LVAD deactivation is very similar as a vent removal. We definitely coordinate with the LVAD clinical staff, the RNs, and understand because each LVAD is different. So you really have to know how to turn it off and what that will look like and what that will sound like. So coordinating with them, um, making sure that the patient and the family is well aware. Sometimes the beeps and the sounds that can occur can be very distressing for the family because they don't know what it is. So understanding what will happen and communicating that very clearly to the patient and family, making sure that the patient is DNR, DNI. All hospice patients are not, and that's okay. But for an LVAD removal, we definitely want to make sure that is in place. Survival after LVAD deactivation, it discussed. I have not seen survival very long at all. It's really been minutes. But, of course, there's going to be that one patient where it is longer than we anticipate, and always just making sure that the family is prepared is better. We also want to make sure before the LVAD is removed, other life-sustaining treatments like feeding tubes and that kind of thing should be discontinued before we do that. The recommendations do talk about having both sub-Q and oral. We don't do LVAD deactivation with oral medications. They're typically available in the home because the patient's probably been on hospice prior to that. But if we really do use the sub-Q or IV route if that's available. And we have an interdisciplinary team present in the home, monitor symptoms closely, and then the IDT support is provided to the family, and even the team that's doing the LVAD removal. So again, something that we do with some frequency, not a lot, but it does happen from time to time. I want to we talked about the heart failure being uh, you know, a it's really dependent on how our patients have access to our healthcare system. A lot of it is that. And I'm not talking just about just the hospital and clinical staff, but all the things that lead to heart failure from the beginning. As I mentioned before, that heart failure is a lifestyle disease. Theoretically, if we all lived the right lifestyle, which I don't, but I try. We potentially could eradicate most of heart failure. Again, that's just theoretically. But this was a patient, a 69-year-old Black woman, had been in the hospital multiple times, had been referred to the advanced heart failure clinic and missed clinic appointments repeatedly. She had combined heart failure, with an EF of 10%. History of diabetes, hypertension, and struggled with housing insecurity. She lived in some tents right by the downtown market from time to time. A lot of psychosocial factors. She did have some family here in Grand Rapids, and sometimes would be living with some family, just staying on their couch for a few days. Um, and because of all of her unstable housing situation, she had a lot of symptoms. And when she did, she would go into the hospital. One time she was hospitalized, and we got called to go see her because I had not been able to see her, just because she missed so many clinic appointments. And oops, I'm going to finish that. And when we saw her, she had very good health literacy. She knew what heart failure was. She knew what made it better. She knew what made it worse. She understood the things that impacted her symptoms, and what she hoped for is better symptom control. And really, what she needed was a stable place to stay so that she could monitor her symptoms, so that she could have a pill box out, so she could weigh herself, so she could do all those things. The fellow with me at the time who saw this patient, we ended up writing this patient up and presenting it to Corewell leaders, and this patient was given housing because the cost of her coming to the ED and hospitalizations was so much more than what it would cost for her to get stable housing. Um, and after that housing was provided, she did not have any more ED visits or hospitalizations. She ultimately died in hospice care after about 4.5 months, but it was a huge cost saving to this healthcare system. But even more importantly, it was a dignity promoting intervention where she had stable housing, was able to manage her heart failure. Um, so as we know all this, why is there such a hard time integrating palliative care and heart failure? In spite of all this data that I've presented to you, our heart failure clinic is still not quite as robust as our oncology clinic. And part of the reasons that it is that there is that prognostic uncertainty, and cardiologists are not entirely trained around that. There's a great misconception about palliative care. I know that's everywhere, but I think that cardiology is lagging in that quite a bit. There are some systemic and workflow barriers, um, the equity and the disparities in access. And there's also there's the lack of clarity in the primary versus specialty palliative care role. Oftentimes, cardiologists uh, only get palliative care involved in end of life because they are able to manage many of the symptoms, not all, but many of them. And so there's a lot of these things really do create barriers in getting palliative care involved earlier on. And one of the things too that there's really not a shared model of how palliative care fits. What cardiology might be looking at it and how we might be looking at it just really doesn't align. And these this partnership really does need a clear role of delineation, workflow integration, some really systemic things in place to allow for that collaboration and partnership. I'm going to skip this case and actually open it up. I'm just going to go through the guidelines for hospice eligibility and then open it up for questions or comments. This is a tier three, as we talked about earlier, that, hospice and end of life, last 6 months or so, we guess. But what is the NIPCO guidelines for hospice eligibility? What NIPCO has said is once the patients have been optimally treated with the guideline directed medical therapy, and they continue to have symptoms, or they're having symptoms at rest. So New York Heart Association class 4. The other supportive factors are things like any arrhythmias, any history of cardiac arrest, unexplained syncope, um, any embolism of cardiac arisen or maybe CVA, any other comorbidities, for example, HIV or even other advanced dementia, those kinds of things. An LVF of 20% or less is what they say, but you don't have to have that. Um, the hospice criteria is just not as cut and dry as it is for oncology. Again, class 3 or 4. But we know that that can change. A person with the class 3 symptoms, you kind of diurese them out. They can get to class 2. Does that mean they're no longer appropriate for hospice? Well, looking at the whole clinical picture is really important to do. So, looking at the refractory symptoms, looking at multiple hospitalizations, even if a patient's symptoms are only during an acute episode, but they've had frequent or increasingly hospitalizations, that can be a very good supportive a criteria for hospice. Again, you have to have a life expectancy of 6 months or less, and then the shared decision making. I'm not going to preach to the choir on that. So again, takeaways, it's a syndrome, it's complex. Health literacy is foundational to it. It's unpredictable. It is progressive. Non-pharmacological interventions are effective and they should be utilized. And again, the goals of care from the very, very beginning, which health literacy is a big part of, and using that interdisciplinary team approach. So these are my references. I am going to stop sharing my screen and open it up for any questions, comments.
Questions from any of the fellows?
Hey, this is Andrea Morse. Can you guys hear me okay?
Yeah.
Hey, so I'm one of our nurse practitioners at Trinity Health St. Mary's, and I have been working with our cardiology group at the WEGI Heart Failure Clinic for a couple years now and integrating palliative care into our heart failure clinic. I just want to share a little bit our experience. I was really fortunate to have buy-in from cardiology very early on, a lot of enthusiasm for having palliative care involved with our heart failure patients. Our barriers have been primarily logistical.
Mm.
Spent a lot of time, building out the clinic and Epic and that sort of thing, and trying to figure out the best way to get the referrals. My time there, unfortunately, is quite limited. But a lot of what you said is very validating. And one point I'll share is we pivoted a little bit because it was easy and obvious getting me involved with the later stage, more advanced stage, but we were already seeing a lot of those patients in the hospital.
Mm-hmm.
And so I decided to start trying to catch these patients further upstream in clinic. And one of our inclusion criteria is new heart failure diagnoses. So I go in with the brand new diagnoses. I kind of do an assessment and evaluation on that needs based approach and say, hey, what are your needs currently? Because everybody's different. And I have found that with new diagnoses, people are looking for a lot of emotional support, spousal support. Spouses are kind of upset and, have a lot of questions. So it's been very beneficial at the very beginning to have us involved.
That's a really great point. You're right that at the time of diagnosis, people are looking for more support and resources. And that's a great trigger. I applaud you at Trinity for the for that involvement. That's really fantastic.
Um, is it hard to start a program, and do you find that cardiology is accepting? I mean, I pretty much have heard it from people and know the answer, but what is your experiences with
I'm
it?
sorry, is what? I didn't hear your first part.
Was it hard to start a program?
You know,
Um,
our program started probably 15 years ago when we didn't have all this robust data. It and I would say that y- if you're starting it now, I think would be a lot easier now to start because it is just really now the standard of care. And to Andrea's experience, I think getting that buy-in um, is becoming easier. There's still a lot to it. The logistics of where you're going to see the patients, how these referrals are going to get done, like all those things are still challenges. But I think, and maybe this is my optimistic side, it is getting easier. I think. I don't know if anybody else agrees with me. I think it was a lot harder way back when we didn't really have a lot of the data to support what we were doing, and now you can really show the benefits of it. And palliative care does translate into some of the improvement of some of the quality metrics that are being measured. So I think yes.